everyone for yeah. So let us get started. I'll give a brief introduction about One Health Knowledge Cafe and very brief introduction of our four speakers. We're going to share COVID-19 situation, country responses, and lessons learned from four different countries, from four different continents. So very exciting sharing from four countries. Without further delay, I would like to start. Can you see my screen and can you hear me well?
Yes, perfect.
Okay.
Yes, yeah, we are clear here.
Thank you. So very briefly, as you saw in the advertisement of this webinar in this talk program, this is being organized by the One Health Knowledge Cafe group. So One Health Knowledge Cafe group is a collaborative effort of more than 11 individuals representing CIS partners, so Center for International Health at Ludwig Maximilian University, so partners of CIS and alumni of CIS. This is One Health Knowledge Group, and this network represents Asia, Africa, Europe, South America, and North America. And this brings together the expertise and network of researchers and professionals from various disciplines, countries, expertise. And the idea is to enable cross-learning, sharing, and network building. And we have a plan to organize monthly talks, webinars, online courses, and discussion forums. So maybe towards the end of today's program, we'll talk about some of the upcoming events. But generally speaking, we are basically facilitating dialogue and discussion and learning from each other. And this initiative is supported by the Center for International Health at Ludwig Maximilian University in Munich, Germany, and CIS-LMU is supported through German Academic Exchange Program known as DAAD, and through the exit program, and eventually it's funded by BMZ, Federal Ministry at Germany. And in today's presentation, so this One Health Knowledge Cafe is supported by a number of collaborators from different countries, and we have a plan to even expand this collaboration. And this map shows our current and upcoming collaboration. And today we are going to hear from Bolivia, Germany, Ghana, and Nepal. So we kept the order based on the alphabetical list of name of these countries, and they represent different continents, as I already said. I don't think I need to tell about all these countries, and probably I will not be able to, but this is just to reflect that these countries are from different continent in the globe, but also in terms of population size, in terms of the literacy rate, and in terms of the economic status and health system, health workforce, they represent diverse settings. And the idea is really to learn from each other. And one thing that might have worked in European setting might not work in South American setting, but there might be things that we can learn from each other. So the idea is to learn from each other, discuss what might work around the globe and what might have to be adapted in a specific country setting. This is the idea. And also in upcoming webinars in August and following months, we'll try to invite speakers from different countries, different continents to have diverse views, and also from different disciplines. On behalf of the Knowledge Group team, I would like to thank our speakers who have taken time to prepare and present today in their country situation, responses, and lessons learned. Afterwards, we'll have discussion. So the first speaker is Dr. Carlos Pinto, who is working at the Center for Graduate Studies and Research at University of San Francisco at Xavier. And he is also working in a number of other poverty-related diseases, especially Chagas disease. And he's biologist by training and is specialized in evolutionary ecology. So very interesting profile. And thank you, Carlos, for agreeing to share experience from Bolivia. The second speaker is Gunter Frossel from Germany, who is also one of the member of Center for International Health and taking forward a number of activities under Center for International Health. He's a medical doctor by profession and a specialist in infectious diseases and tropical medicine, and a senior lecturer and researcher at LMU Munich. The third speaker is Gloria Ivy Mensah, who is a research fellow at the Department of Bacteriology, Noguchi Memorial Institute for Medical Research at University of Ghana. And fourth speaker, last but not least, our Mr. Bhim Sapkota, who is currently enrolled in PhD program at Center for International Health, but here back in Nepal, he is working with Ministry of Health and Population. So we have speakers from different background and discipline, but all of them are focusing on sharing country situation and probably focusing on some parts of the country as relevant or based on their role, and also the country response activities for COVID-19 and some of the lessons learned or some of the points that we need to discuss in today's program. And the objective of this program is to share current situation of COVID-19, country response, and lessons learned across selected countries, to review and discuss key lessons learned for the global health community, and to establish a better network to promote learning and collaboration among CIS partners, alumni, and beyond. So through these programs, we'd like to invite people from other areas who are not currently part of the CIS, but we are always open to explore ideas for further networking and establishing collaboration for research, for academic purpose, for programs, and so on. Before we jump into the presentation, I'd just like to share some housekeeping rules. So we would like to request all of you to keep yourself muted unless you are speaking. Would like to request you to keep your video off if you are not presenting. So presenter can put their video on, but all others would like to request you to put your video up, because this might help with the bandwidth, and some of the participants joining today might have weaker internet connectivity, and that might help us with the connection and smooth flow of the presentation. I'd just like to inform everyone that this session is being recorded, and later on we have a plan to share it, and the PowerPoint slides that presenters have prepared will also be shared, and we'll discuss about that later on. We'll have Q&A session at the end of all four presentation. We encourage you to put your question in the chat box. If you have any specific question to the presenter, just for clarification, we may take one or two questions, only for 1 or 2 minutes, just clarifying question and only to the particular presenter immediately after the presentation. But for other questions, please hold themselves to be discussed at the Q&A session at the very end. And in case of any interruption on presenter due to internet, we'll wait for maximum 2 minutes and we'll move to the next presenter, because sometimes because of connectivity and other issues, we may face this kind of problem, and we just want to clarify this arrangement with all of our participants. As I said earlier, the plan is to have quick introduction that I just provided, and we'll have 4 country presentations. So each of them will take about 15 minutes, and following that, we'll have time for Q&A and discussions. So with this one, I'd like to hand over to Sabina Sigdel, who is the program coordinator for this webinar session, and she will be facilitating next steps onwards. So over to you, Sabina.
Okay, thank you, Deepak sir, for all the introduction and briefing of this webinar. So I'm Sabina Sigdel, and I will be the moderator for today's webinar. I would like to welcome all the participants in today's webinar. And as already Deepak sir mentioned, we'll be discussing about the country-specific situation responses and lesson learned of COVID-19 in 4 districts. So we have our first speaker, Carlos Fernando Pinto Nevia. I'd like to request Carlos, to present his presentations. Over to you, Carlos.
Thank you very much, Sabine. Okay, good morning to everyone, and thank you for the invitation. I will talk today about the situation, responses, and lessons learned in Bolivia about COVID-19. I am Carlos Pinto, and I am a researcher at Universidad San Francisco Javier de Chuquisaca in Bolivia. About the situation of COVID-19. First, about the situation of COVID-19 in Bolivia, the first case was identified at the beginning of March in a migrant woman returning from Italy to visit her family. So we become the 12th country of Latin America infected. Below, we can see a graphic seeing the number of cases and the growing of the number of cases in Bolivia. In the blue points, we can check a growing of around 6,000 people per million persons, and also a rate of fatality of almost 4%, and a recovery rate also of around 30%. One of the main problems right now is that the whole health system is collapsed. Hospitals and emergency centers are full of patients. The lack of resources and personal protective equipment in healthcare centers is also become another problem because many of the medics who are working there are becoming also patients. The treatment uncertainty for COVID implies that the evolution of methods to attend the people are also not clear until now. The lack also of a clear protocol for diseased persons is the uncertainty about short and long-term effects of quarantine. For example, in the psychosocial aspect, mental health is not taken too much into account. In the economic aspect, around 70% of the population have an informal work. So that means that they can support like 3, 4, or 5 months of quarantine. In the educational aspect, there is a lot of conflicts between parents, teachers, schools, in many aspects. And also, as usual, there is also political conflicts who performs a worse scenario in some cases. There is some headings of newspapers, Bolivian newspaper for only 2 or 3 days ago. For example, Oruro, a region of Bolivia, it is confirmed that 30 deceased by COVID-19 were buried in a mass grave after more than 15 days of abandonment. Thousands marched and announced a strike demanding early elections in Bolivia. Election must be in May, but because of the quarantine, it's going to be delayed until October, but we are not clear when is the right time to do it. COVID-19 without plan and with collapse in health system, the country enters in a critical phase. In this graphic, we can see the evolution of key points about the pandemic in my country. For example, the first case was in March. After some days, around 21 of March, is declared the national lockdown, who lasts at least 2.5 months. The central government decides to help vulnerable population with a first cash transfer of around $72 in May. After, in May also, regional laboratories who counts with RT-PCR methods are incorporated because we only count with 3 laboratories in the main cities of Bolivia, La Paz, Cochabamba, and Santa Cruz, and they were in the charge of all the diagnoses from March to May. There is a second change of health minister by corruption scandal who happens at that moment, also in May. And after, in the beginning of June, national lockdowns become a sort of regional lockdown. That means that each region have the capability to decide how they want to continue with this measure. And a second cash transfer is also planned for the next days. The number of tests performed in Bolivia is really low. We only have around 11 tests per 1,000 persons. That implies that only symptomatic and key groups are identified with a positivity rate of 65%. A second big issue is traceability, where in my country we didn't have clear protocols for tracing all the cases, and also few resources are allocated for this task. Which are the lessons learned about it? Quarantine and biosecurity measures were effective, meanwhile were strictly applied. But just after the lockdown becomes flexible, the number of cases started to grow up and we didn't have a clear idea of what's going to happen after. Regions with a higher rate of coordination between authorities deal more effectively against COVID. It's important, the coordination. Early diagnosis and traceability system seem to be key factors to control the incidence of COVID. Education and communication are important to avoid stigma and despair in the population. So important considerations. The education and awareness of the population is very important. There is evidence-based health policies and bioethics need to be strengthened. For example, there is an indiscriminate use of some medication, for example, chlorine dioxide, ivermectin, who are used as prevention but indiscriminately and are self-medicated in many cases. There is also unclear protocols for COVID for care, referral, and treatment. And some not so clear randomized clinical trials in vulnerable population using some of these medications. Indigenous communities with limited access to health. We are a plurinational state of Bolivia. That implies that we are around 37 indigenous nations inside only one country. That means that these 37 nations are from a long time ago isolated in some way, and now their situation is worse. Political conflicts and corruption were accentuated in this period. And our main points for question and answer sessions are, is decision-making better at the local or national level? What is the role of primary care for case detection and management? How important is the adequate traceability of positive cases and suspicious cases? And how to proceed if it can no longer be isolated? Thank you very much.
Okay, thank you, Carlos, for your very informative delivery. So as a reminder, I would like to remind all the attendees or the participant that if you have any particular questions for Carlos, you can just type it or enter it in the chat box and we may address it at the end of this presentations. We have allocated 30 minutes of the sessions for the Q&A sessions and we can, the panelists or the speakers can address it. So with this, we have our second speaker, Dr. Günther Frossels from Germany. So I'd like to hand over to Dr. Günther to share his presentation. Over to you, Günther.
Yeah, thank you very much. Can you hear me?
Yes. Yes, we can hear you.
Sorry, Günther, now we can't hear you. You are muted.
We can hear you.
We can't hear you.
Now you can hear me back.
Yeah, it's perfect.
Yes.
Now?
You can hear, yeah. Right now I can hear you.
All right. Okay. Can you see my screen?
Yes, I can. Yes, we can.
Okay, very good. Okay. So good afternoon, everyone. And thanks, Carlos, for having staff to highlight quite a number of points that are also true for Germany. There is some background noise. I don't know, maybe Sabina can check who of the non-speakers is having the microphones on, because there's a lot of background noise. Okay, now I'll try again. Can you hear me again?
Yes, we can hear you, Guinte.
Okay, excellent.
Yeah.
Okay, all right. So, so I'm going to talk about the situation response lessons learned, and I will tell a little bit about Germany, of course. But of course, we have a very peculiar perspective here in the city of Munich, which is in the very southeast of Germany. And why is that so? Because we were a primary entry point, and I will show you in a minute why that was the case. Now, okay. So as was pointed out by Deepak already, we have a population of 84 million people. We have a federal country, so Germany is divided up into federal states that are pretty much functioning independently. So actually the different states, so Munich is in the state of Bavaria. The state of Bavaria has about 13 million inhabitants. So each state is functioning pretty much independently. So a lot of the regulations were started quite independently by the state of Bavaria and by other states. So we were seeing in the course of this pandemic quite some shortcomings of this structuring of Germany, because me and a lot of people were convinced that we would have done a better job if the regulations would have been put up nationwide. Here on the slide, you see as of 22nd July 2020, 204,000 cumulative cases. Today we are at 209,000 cases. I think everyone knows the GIS and data dashboard by Johns Hopkins University. I mean, it's pretty much close to what the official data shows from the German Institute of Public Health. Why was Munich in the southwest of Germany? And I'll show you a map in a second. Why was it so important? Because of this company. You can see the company name. This is a automotive parts producer and deliverer to a lot of the larger automotive companies. So they are producing parts of cars, so quite an important industry, and they are located quite close to Munich. Now, the production of many of these parts, especially the electrical parts, is happening in China, and there's a lot of cooperation with China. And so this company has a lot of coming and going between China and Germany, so between German and Chinese staff. And so the COVID virus, and we are pretty much sure that actually in Germany, the entry point was really a single entry of one positive case, because we didn't see any other clusters in the double or triple incubation period, but only in this company. So we had only this company attained by a Chinese business lady that traveled to Germany, traveled back to China, was well all the way along, and then infected a number of people in first and second generation and third generation, even infections all along. So we had a very well-defined first cluster in this company. Why am I saying this? And I think Ivy Mensa, the next speaker, will smile, because I'm saying we were just lucky, and it's all a question of coincidence, because all of our measures we could test with this one company. Yeah, so we have this one company that you can see on the picture with a defined number of staff. You could close down the whole place, lock everyone up at home, or hospitalize everyone that was tested positive. And we could build up our testing unit that is just outside this window here in front of me that I'm now responsible for. And we had the first positive case, that was a German case from this company, on 27th of January. So this is the very first German case that we detected actually in this facility here. Okay, and so we were very lucky, because we would have gotten COVID anyways, but we had a very nice test balloon, this one company, where we could actually see, wow, so how do you deal with patients? How do you keep them? How do you test them? How do you transfer them to the hospital? And how do you do contact tracing? And so as our just previous colleague was pointing out, contact tracing is really an issue. So with this company, we had quite an easy game to do contact tracing. Now, on the next slide, you see now a map of Germany. And so this southwestern part with this red circle, this is, so the larger part here is Bavaria, and the circle here is around Munich. This is where we are located. This is important now for the second period of clusters that arrived in Germany. And I'll show you on the next slide why that is so. There's another red circle here in the western part of Germany. This is North Rhine-Westphalia. Why is this important? Because North Rhine-Westphalia resembles pretty much the landscape and the social demographic situation in another hard-struck country in Europe, which is Italy. Yeah, so Italy was not so lucky, and everyone says, well, Germany is just doing better because we are so good in everything, but that's not the case. We were just lucky, yeah, because we had this one test balloon and were prepared. Later on, when we had the second phase of introduction, which were all the travel returnees that were coming back from countries like Italy, and of course they were spread pretty much over Germany, but it is very common for people from the southwestern part of Germany to actually travel to Italy, yeah, because we are just almost neighbors. There's Austria in between, but anyway, it is quite easy to travel from Munich for a weekend trip to Italy, and many people are doing that. So the second phase, we had travel returnees coming back, and traveling to Italy is very common in this southwestern region of Germany. Of course, later on, people were also returning to other places, and then movement within Germany kicked in, and then we had clusters everywhere. And now North Rhine-Westphalia, which is the second largest circle, has a population of 17 million. It is an industrial region. It is densely populated. Lots of people that are much poorer, lots of people with migration background, lots of people that are originating from other countries that then had COVID problems, also from Italy, Spain, from Greece, from Turkey, lots of migrant workers. And then we had this second area in Germany that was attained. Now, here you see a map of Europe to highlight a little bit. So there was one region in Europe that was keeping us busy for a very long time until other areas kicked in. Now we know United States, Brazil, India, and so on. That's now a completely different story, but for a long time, that was in February, March, the hotspot and the hot pot of Europe was this area here, which is the northern part of Italy. It's the Po plain. So it's a lowly located, so low altitude, quite flat area with the Po River that you can see as a blue line here into the Adriatic Sea. And that's densely populated, again, lots of industry, high total number of population, and again, due to the industrial engagement, lots of in and out of professionals, and also from China, because also they are producing parts of automotive industry, also medical equipment. Quite funnily enough, at some stage we realized that our FFP2 face masks were actually coming from Wuhan in China, and then all our swabs that we were using were actually coming from Brescia in Italy. So we were wondering,
excuse me, Gunther.
Yes.
Can you make the slide bigger? You can make the slide so now, so it's smaller for the audience to see the presentations.
Okay, is that better?
Yeah. Thank you so much.
Okay, very welcome. Okay, so Po area, and this is Munich. This is where we are, and lots of people traveling forth and back. So lots of interaction. Okay, so the key interventions. What did we do? Yeah. As you can see here again, the first 5 cases in Germany were detected in our facility. In 4 of them, it was me myself that was doing the swab actually of these cases. That means 27th of January was the first case, and we realized we need to do something more than just opening up a room here, but we needed to establish a testing unit. And so that was the day after, on 28th of January. First, we were rededicating a floor here in our building. And then later on, we opened up a tent out in the street that was roughly 6 weeks later, or 7 weeks later, when we closed down a street out here in the center of Munich and opened up our testing unit. We had changing testing strategies and case definitions. Maybe you've heard of the philosophy of containment. So to say, okay, we really want to avoid and really isolate each and every single case. Then there was control to actually try to reduce the risk and reduce the numbers, but not to eliminate entirely. And there was this funny idea of herd immunity. You all heard Boris Johnson talk about it, but there were also reasonable scientists that were thinking about it. So all these were ideas that also we were reflecting here. In the beginning, we were actually really thinking about containment because we had this one company and we were quite able to really control it. And after this first cluster, there were no cases anymore until the travel return is coming back. Management. Of course, hospitalization. We reached close to certain limits at certain hospitals, but not throughout all of Germany. I think we always had enough capacity in our hospitals, also in the intensive care units. I think there was never really a very hard triage saying, well, we will ventilate you, but not you, as was the case then in Italy, which is very dramatic. Quarantine, different philosophies. In the beginning, everyone was hospitalized, even if people had no symptoms. Later on, then even positive patients with mild symptoms were quarantined at home. And yeah, ICU I was talking about. I agree with Carlos that community engagement is very important. I just want to say that we had a complete lockdown in Germany. Well, it was around the weekend of 20 to 23 of March when the country was locked down. I'm very much convinced if we would have had the lockdown just 1 or 2 weeks earlier, it wouldn't have worked that well because people wouldn't have accepted it. It needed really the bad press, in quotation marks, about the terrible things that were happening in Italy and about rising case numbers in Germany, so that everyone understood in the end, look, now there's really something going wrong and we really need to stay at home, put up face masks, and then really also a city like Munich that is very lively in spring and summer times was a ghost city. I've never seen anything like this before. There was lots of communication. We had well-known scientists that were giving podcasts and so on. And so at some stage, I had even the impression that we were over-informing people. A lot of people were also getting confused about it. Social distancing, yeah, we saw quite a range of between people that didn't accept it at all and didn't care about it, but a lot of people really kept very strictly to social distancing, so really avoiding you when you were getting close. So some people, healthcare workers, still had to go to work, but otherwise public transportation was very empty at the time. You had a whole compartment for yourself. But later on, when everything was loosened up, then people were getting close again. But now in public transportation, you still have obligatory use of face masks and also in publicly accessible shops. Here you can see a picture of public toilets, for example, where you can see that it was made sure that you don't get too close while peeing to your neighbor. We had always enough protective equipment. Sometimes we had to be a bit flexible with it, but we never ran out of anything. And we saw a lot of stockpiling, both with protective equipment, so professional equipment. Funnily enough, at our university hospital, the administration at some stage, they just passed through the entire university hospital and just opened up the stock of at each department and said, well, funny, you have a few hundred gowns and face masks. So they actually confiscated everything and then provided it to places like us that had really more use to it. We saw funny situations in supermarket where people were actually stockpiling things like noodles and toilet paper, which I never understood in the end, but it's quite funny. Research, we are doing prevalence studies on antibodies here in Munich. That's us with 3,000 households, randomly selected 6,000 people. And we do vaccine studies, so a phase 1 vaccine study in people that had a proven past COVID infection to see about vaccine safety in people that already had the infection. So we are engaged in that since a few weeks back. Lessons learned. So I would say I would like to subdivide into controllable and uncontrollable aspects. Well, what you can control is commitment. Also a political thing. The health facilities need to be prepared. You also need to be flexible, and people need to be accountable for what they are doing. And of course, it needs global action. There's no way that containers with materials are held back that are about to be delivered to countries that have more use and are in dire need of them. And we saw that in Europe. Yeah, it was really a crisis of solidarity in Europe, as I would call it, which was quite a sad thing to see. Things that you can't control, again, is commitment, because some people reacted, also politicians, in a way that you could not predict really much, and you don't quite see why that was. There's lots and lots of coincidence. I would like to remember this one company that we had as a test balloon. It's all about luck and hidden agendas in politics and in economy. For future time considerations, we have to expect more of the COVID kind. Yeah, I mean, a few years back we had Ebola. I was working with Ebola, and now we have COVID. We will have other things in future time. This is not an exception, yeah, and we just have to understand it now. This is not an exception. We have to be prepared and prepare for contingency for these situations. We need to be prepared, but yet flexible. Yeah, so we need to be flexible because the next thing that will come up will be different. And the same thing, one size fits all, is not going to work. We need to communicate globally, especially within Europe. I was very sad again to see that solidarity didn't work well. And the community needs to be involved properly. I'm quite convinced of that. So things went better in Germany than in neighboring countries like in Italy, but just because of mere luck. Yeah, Italy was not so lucky after all. Thank you so much.
Thank you so much, Carlos. Sorry, Guenter, for your interesting presentations. So it's good to hear that what Germany has been doing and what are its lesson learned. So I like the point that we have to be prepared more of this COVID kind. It's uncertain that we can face any of this infectious disease in near future, and we need to be prepared of that. Thank you so much. So with this, now I would like to invite Dr. Gloria Ivy Menas to share her country-specific experiences on COVID-19 from Ghana. Welcome, Gloria Ivy.
To unmute.
Yeah.
Okay, that's fine. So hello to everyone. And let me go straight to my presentation. I hope you can see my screen. Okay, good.
Yeah, Gloria,
Okay,
again, same request to you that you can
make it bigger.
Yeah, make it bigger. Yeah, thank you.
Okay, great. All right, so let's get right to it. So the population of the country was already shared. So we are just around 30 million. And this is where you find Ghana on the map of Africa. Currently, Ghana is the fourth highest. Ghana has the fourth highest number of cases in sub-Saharan Africa, after South Africa, Egypt, and Nigeria. And that is also because we are doing more of the testing. So how did it all start for us? And as you can see from the newspaper clippings here, the first suspected case brought about a lot of nerves. There was panic in the hospital where the suspected cases were being quarantined. Luckily, those 2 cases ended up being negative. But then it showed that we were not as ready as we thought we were. So in trying to calm the nerves, dedicated phone numbers were rolled out. So if anybody felt they had symptoms of COVID, they could call the numbers instead of showing up at the hospital to create a lot of chaos and panic. And some hospitals were set aside to have isolation wards. And also a specialized facility was opened up to take the positive cases. So eventually, when we had our first positive cases on the 12th of March, we were sort of ready to contain the situation. And this was swift because within like 3 days of the announcement of the first cases, the basic level educational system was closed down, so school children stayed at home. And I think within a week of that, those in the universities and the secondary schools were also asked to come back home. Most of those were in the boarding facilities. And in addition to that, markets were fumigated, all in an effort to quell the spread of the virus. Of course, at this time, we had moved on from just having the imported cases because our first few cases were actually imported. So we had begun to see the community spread. That's why all these measures were taken. Eventually, we had to have a first lockdown of 2 of the major cities in the country because most of the cases, again, were coming from these 2 cities. But the lockdown also brought about a lot of challenges, which I will talk about in the next few slides. So eventually, the lockdown was lifted. and that decision was questioned by a lot of people. Some people were not happy about that. Others felt if it was not lifted, some people would have died out of hunger more than the COVID. So it was more of whether the decision, a lot of people were questioning whether it was based on science or it was politics. But at the end of the day, it was lifted. But then the restrictions set in. So although the lockdown was lifted, there were restrictions about physical distancing, congregation. So churches had also been closed down. And then finally, somewhere in the early part of June, although the cases were still going up, it was thought that we understood the movement of the virus better. So we had a reopening of the churches and mosques. But then again, they were limited on the number of people who could be there at a particular time, and you could only hold the service for just over an hour. And of course, everybody had to be in face masks. The people entering the churches, the mosques had to be registered. So in case of a positive case, it would be easy to trace the contact. So now schools were also reopened eventually, just for the universities, so final year students could finish up their thesis and graduate, and also for those in the secondary schools to write their final exams, because in September, students are supposed to move on to the universities. Of course, in the midst of all this, we are supposed to have our national elections somewhere in December. So we started a voters registration exercise, and that was met with a lot of concern, whether it was based on science or politics, but is ongoing as we speak. And then further restrictions were lifted just recently, last week. So for now, churches can accommodate any number of worshippers that they want, provided those worshippers were seated one meter apart. So it's like in the midst of the cases going up, we are being told to get on with our normal lives because we don't know how long the virus is going to stay with us. So a closer look at the Ghana's response strategy. So we have been having regular presidential addresses. I think we've had about 13 addresses so far since our first case. So these briefings, the president usually comes up with whether we have any new measures, and also reinforces the nation's strategy, which is to limit and stop the importation of the virus, contain the spread, provide care for the patients, limit the social and economic impact, and then just expand the domestic capacity of the Ghanaians to deal with the situation. So basically, they have been touting these three words: test, trace, and then treat. And I think one of the statements he made went viral because it touched at the core of what we are dealing with. So he basically said that he knows how to bring the economy back to life, but he doesn't know how to bring people back to life. So whatever we needed to do to contain the pandemic, we had to do that. And so in so doing, we have had a lot of incentives because, as you can all imagine, things have been really hard in these times. A lot of people are staying at home. Workers are not, some workers are even not being paid because they are not doing any work. So we have had tax exemption for health workers because they are working around the clock to deal with the situation. And because of the aggressive contact tracing that was initiated initially, the contact tracers were also given allowance. Currently, all healthcare workers are getting an additional 50% allowance of their basic salary. There's an insurance package for workers caring for COVID-19 patients. And the whole country is sort of enjoying water and electricity subsidies. So 100% for the very poor and 50% for businesses. But at the heart of all this has been two research institutions. So on the top here is the Noguchi Memorial Institute where I work. And this is a KCCR in the middle belt of the country. And really, had it not been for these two research institutions, I don't know where we would have been, because Noguchi started with the testing for the first cases and was later joined by the second institution. Also because, as we are all aware, the test being used is a PCR. And in Ghana, most of our health facilities do not use PCR. So it was left on the shoulders of the research institutions to do that. And in trying to keep up with the numbers, they devised a lot of innovative strategies. For instance, Noguchi was doing pooled testing at some points because for the contacts, a lot of the times the results were negative. So it was thought wise to pool the samples of 10 contacts together. You test if it's positive, then you do ampouling to find out which was the positive one. And this was one of the strategies that allowed us to test a lot of cases within the shortest possible time. Also, at some point, as we are all aware, there was shortage of supplies. And so we did not have access to swabs to take the samples. So we resorted to taking sputum samples for the test. In Noguchi, we have also seen delivery of samples via drone, because as I said, these were the two major centers testing. And so if you had a case in a remote area, how would you immediately transport it? So we have had delivery of samples by drone. KCCR has a mobile lab that has been deployed to hotspot areas to facilitate the testing. The good thing is that now we have about 10 facilities doing the testing. And those that I've highlighted in red are actually veterinary laboratories. This was just to highlight the One Health approach. I mean, when it gets to this point, we all need to put our shoulders to the wheels and work together. However, we are hoping that when eventually the GeneSpect is rolled out, we'll be able to have more testing facilities, because if you look at this map here, all the red dots are facilities where we have the GeneSpect machines. That's a little over 130. So if we're able to roll out this, then we will be able to increase our testing capacity. But in spite of all this, like every other place, our cases have been going up. You can see clearly from this graph, COVID is not going anywhere. My slides are frozen at this point, okay. And if you look at the cases of Ghana compared to the countries here, Germany, Bolivia, and Nepal, you can see that you can compare the number of deaths we have had. Luckily, we've been lucky. We have had fewer deaths. I mean, compared to Nepal, we still have quite a number of cases. My laptop is freezing on me. Sabina, can you help? Oops. Hello?
Hello, is there any problem, Glory?
Yeah, it seems the screen is frozen. I can't move.
Yeah, maybe I can help you with the...
Yes, with the next slide.
So you can turn off your screen now.
Sure, okay. Okay. I'm off my screen, so if you could show that quickly.
Yeah, okay. Yeah, this one.
Yes, so I think I was on slide number 10 or so.
Is this?
I'm not seeing it.
Yeah, I'll share it. Yeah, Ghana. Are you able to see my screen?
No, it says has started screen sharing, but I'm not seeing screen itself. Oops.
So are other participants able to see the screen?
Yeah, I think I can. Yeah, I can see it now. Okay, so we can just move to the next one. This was just showing the comparison between Ghana and the countries represented in this webinar. So we can move to the next one.
Is this?
No, the next one. Because I'm still seeing the same screen.
Okay, I want to take views from other audiences, whether they are seeing the
So
screen
just
that
back.
I'm
Yeah, I'm
sharing.
seeing that now. Just go back one more.
Okay.
One more.
Okay.
Yeah. Okay. Then we can move forward. We can move forward now.
Okay.
Okay. So basically, this is where we are now. How is life in Ghana now? Most of the to enter any shop, any facility, basically you need to have your temperature checked. You wash your hands. Luckily, we have this what we call Veronica buckets, which are basically plastic buckets with a tap fixed, designed by a Ghanaian lady. So you wash your hands. We have church services, schools ongoing, but everybody has to wear a mask. Physical distancing is ensured, even in public transport. You will find this on the doors of most organizations, insisting that you wear a face mask before you enter. Next, please. Yeah, so what are the challenges? We still have challenges with the attitudes, enforcing the protocols. Most people complain about wearing masks, they can't breathe. We have had a few issues of stigma with people who have recovered. We still have myths and misinformation about treatment and prevention. I mean, if people have their own opinion of how to prevent the disease and the treatment strategy. And there's been a big issue of infection control, especially among health care workers. And this partly has been blamed on the availability and distribution of PPEs, the inequitable distribution of the PPEs, and the delayed test results. I mentioned earlier that still we are not able to roll out results in 24 hours, also because of the limited testing capacity of the two institutions. And also, we have had a situation where other diseases are being neglected or overlooked because all of us are focused on COVID. And almost every decision that comes up is there's an argument over whether it is scientific or just political expediency. The next one, please. So what are the major lessons learned? On the part of the government, I think we have all seen a pandemic affect all aspects of life. And particularly for Ghana, the challenge has been with our healthcare delivery. This pandemic has really exposed the inequities in essential equipment and skilled staff, the distributions. Everything is concentrated in the major cities and at the expense of nothing much in the outskirts of the country. So as a result of that, we have, the government has announced a plan to have 3 new infectious disease centers and a lot of other hospitals well equipped to be built over the period. And the good thing is that for the first time this year's budget, we had an allocation for research, because I think everybody in the country, including the government, has seen the importance of research institutions and the work that we do in supporting the nation. And also during the lockdown, we realized that we really needed to have information on who the poor were and where they were, because during the lockdown, trying to identify the poor for targeted interventions was a big problem. Next one. And for the citizens, I think we have learned a lot. We have learned that we can mobilize when the need arises. We have seen donations from individuals, industries, religious organizations towards the testing, and even a fund has been set up which recently built a new infectious disease hospital within the shortest possible time we have ever seen in this country. When we ran out of imported sanitizers, we had local production of sanitizers, face masks, hand washing sets, full body sanitizing equipment, all locally engineered. And of course, we have all had to learn to embrace technology. Schools, mosques, churches were all doing their activities online. And for us as Ghanaians, I think the major shock to our system has been actually having funerals and weddings online, participating online. We love big funerals and weddings, so this has been a major shock to our system. And also we have been able to roll out the drone delivery. We have a COVID-19 app tracker for people to look at their symptoms and then report if necessary. And for me, as a scientist from where I sit, I think the biggest thing that we have also learned is that we need to communicate better, because in the beginning there was a lot of misunderstanding between us, the scientists, and the media, because obviously either we have not been communicating the science well, or they have not been focused too much on science to understand some of the things that we do. The next one. It's my last slide. I would like to acknowledge these individuals and the institutions. Thank you very much.
Thank you so much, Gloria, for such an informative delivery. So we got to learn so many things about what Ghana has been doing and what could be the lesson learned for other countries as well. So with this, the final presentation for today's webinar is by Bhim Prasad Sapkota sir, and he's from Nepal. So over to you, Bhim sir.
Thank you, Sabinaji. Let me share my presentations from here. Yes, Sabinaji, is it okay now?
Yes, you can go ahead with the presentation. Yeah, it's okay.
Thank you. Thank you, Sabinaji, and this One Health Knowledge Café organizers for providing this opportunity to present the country experience. I would like to welcome all of you in my small presentation about the country experience of Nepal on COVID-19 response and lessons. And this is Bhim Prasad Sapkota, working at Ministry of Health and Population Government of Nepal. And this is just Nepal. It is located on Southeast Asia. It's a landlocked country sandwiched between India and China. We have three tiers of governance: federal government, province level government, and local level governments. And politically, we have 7 provinces, 77 districts, and 753 local levels. And this is more about the background information about Nepal's health system. We have more than 200,000 health workers registered in different councils, but professionally only 77,000 health workers are active in health sector. At present, our hospital capacity, it means before the pandemic of the COVID, we have only 27,000 hospital beds all over the country and almost 1,600 ICU beds and only 840 ventilators throughout the country. And our health system has the one very few basic health services are free, and we have just trying to expand and scale up the health insurance, voluntary health insurance, but there are so many challenges on the implementation. And we have 60% of our total health expenditure is out of pocket expenditure. And this is about the COVID-19 situation. And I have compiled the information till 13th of the July 2020, that's yesterday. We have till yesterday, we have 19,547 cases, positive cases till yesterday, and it means we have 652 almost cases per 1 million population. And we have the significant thing I need to share here is the death is only 52. This is compared to other country and compared to global scenario, the death is very low. We feel fortunate and lucky to have the less number of fatality. And the first case of COVID in Nepal was diagnosed in 23rd of January 2020. The case was traveled from China, and after almost 2 months, the second case was diagnosed. She was a student, and she has a travel history from the France. And we have almost 97% of the positive cases have travel history. Most of them from the India, and few of them have traveled to other parts of the world. Among 364,000 PCR tests conducted, only 5.36% is the positivity rate of the PCR test. And we have only 0.26% of the case fatality ratio. It is shown that globally it is almost 4%. And this is the trend of the cases. And what I have seen here is, the curve is now first curve is decline already, and by 10th of the July, government has little bit relaxed the lockdown and with the permission to move the private vehicles with odd and even numbers. And again on 21st of the July, government has announced to relax the lockdown with the authority to announce the lockdown and restrictions of the activities at local level and the district level. I would like to share this SAARC countries comparison. In this comparison, we have the second lowest mortality figure among the SAARC countries. That is, the Bhutan is the first position compared to the mortality. They have no mortality and no fatal case. And after that, we have only 0.3, even less than 0.3% of the case fatality. And we have significant number of recovered cases. That is, more than 70% cases are recovered, and only 28% cases are active cases with us. These are some of the key interventions that we have implemented for the COVID response. The first key intervention I would like to mention here is the political commitment. We have COVID Crisis Management Center led by Deputy Prime Minister, and the high-level committee is also led by Deputy Prime Minister that is formed to address the COVID response issues. And we have the focused health system for the COVID response. That is, we have an incident command system activated at Ministry of Health and Population. It is led by Health Minister, and we have activated the Health Emergency Operations Center. Usually, the Health Emergency Operations Center used to be activated only for the disasters, especially natural disasters. But during this pandemic, the Health Emergency Operations Center also is activated and is still working very effectively. And there are some other non-health measures like lockdown and border seal and the banning of the public events and the closure of the schools and the other educational institutions. We have met the guidelines and protocol for the provision of community-based quarantine and the home-based quarantines also. And some of the community institutions and even the schools, public schools, are being used for the quarantine of the people who have traveled from different parts of the world. And the quarantine has been handled by the local level. It is one of the success story of we would like to share to other parts of the world. The quarantine are being handled and managed by the local level authorities. And while we have diagnosed the first case of COVID-19 in Nepal, there was no laboratory facility to diagnose the COVID-19 case. And we sent the sample to the Hong Kong for the test of the sample. But nowadays, we have 28 laboratories throughout the country, and they can do COVID-19 RT-PCR test. And we have conducted several series of human resource training for the COVID-19 case management and the ICU management and the critical care management of the COVID-infected people through virtual network. And we have expanded the hospital capacity. We're adding the ICU beds and the ventilators and oxygen supplies. And even in rural remote places, we started the telemedicine to support the health workers. And we have dedicated COVID-19 hospitals. We have classified them as level 1, level 2, and level 3 hospitals. And some of the hospitals have run the COVID clinics, and we haven't included them in the level 1, 2, and 3 hospitals. And for the asymptomatic cases, those COVID positive cases who have no any clinical symptoms, we have managed them by keeping them out of the hospital. The centers established by the hospital, managed by the hospital in the nearby location, but they have not occupied the resources and the infrastructure of the hospital. And we reserve the hospital beds for the symptomatic and the critically ill patients. And still, till today, we have almost 5,000 cases remaining in the isolation centers. And we have developed the guidelines, standards, and protocols. And these are some of the activities and mentioned in different timeline. First case was diagnosed in 23rd of January. And one of the most the effectively conducted activity by government of Nepal is the 175 students. They were in Wuhan for their study, and we have repatriated them on 16th of February, and we kept them in the quarantine for 14 days. And it was the greatest lesson learned for us to do the COVID response activities through the coordinated effort between local level, province level, and the federal level. And in 24th of the March, just after 1 day of the second case, we announced a nationwide lockdown, the complete restriction of the lockdown, and we expanded the PCR lab capacity. And in 16th of the May, there was the first death due to COVID-19. And in 12th of the June, there was the lockdown was relaxed because there was all the economic activities has been hampered, and the most impact was to the indigenous people and those people who are below the poverty line. They need to survive based on their day-to-day earning, and government has no any option to allow them to conduct their routine activities, minimal routine activities. But there was some public health regulations and the public health measures and the public health precautions to minimize the COVID transmission. And on the 6th of the July, Ministry of Home Affairs, Government of Nepal announced the compulsory use of the mask by every people while they are going out from their home. If they are not wearing the face mask, surgical mask, the police will catch them, and the policeman will punish them. And nowadays, after 21st of the July, government has lifted the lockdown, but the permission to movement and the travel is within the district. And if they need to travel beyond the district, they need to take the travel pass from the government. And by 15th of the August, government is planning to resume the domestic and international flights and the educational institutions. Let us see how the new days will appear with us with the number of COVID cases. If there are more number of cases with the second wave of the epidemic, then we will rethink on this decision. But nowadays, we are planning to resume the domestic and international flights by the 15th of the August and all the educational activities. And this is the site where we can find the educational materials and the resources about the COVID-19. And this is the Health Emergency Operations Center website. We have 2 hotline numbers targeted for the public and the 1 hotline number targeted for the health workers. If health workers have some confusion to manage and to deal with the COVID cases, then they can also call to the hotline numbers. And we have the toll-free numbers, 2 toll-free numbers run 24 hours in the Ministry of Health and Population. We have a mobile app, and we have a website updated daily about the COVID information by Government of Nepal, Ministry of Health and Population. And the fantastic thing that we have tried was we requested Nepal Telecom to play the ringback tone mentioning the COVID-related information. It was the most effective way of delivering the COVID-related information in short time to the people. We feel that it was a new practice during this COVID pandemic information communication way, and we tried it. And ongoing nowadays, we are implementing all the COVID-19 response activities based on our health sector emergency response plan that we have developed after the COVID-19 pandemic. Basically, this health sector emergency response plan has included major 3 components. First component is public health and social measures. Second component is hospital-based intervention. And the third component is management and oversight of all the response activities throughout the country. And the health sector emergency response plan included the worst case, moderate case, and severe case scenario of the different caseload in the country. And we have the one limitation of this health sector emergency response plan is we have estimated, or we have expected to have the maximum 10,000 cases by the end of June. But unfortunately, we have crossed the ceiling, and nowadays we have almost 20,000 cases. But we are trying to keep those cases under our grip, and we are trying to manage all those case loads with minimum fatality. And the other major interventions we are planning to do is we are planning to do the point of entry screening at the ground crossing borders, and establishing the quarantine centers and mobilization of the case investigation and contact tracing team at the local level, at the municipal level, and at the rural municipal level. And we are still trying to expand our isolation and hospital service capacities, and we are trying to mobilize the emergency medical deployment team from the province level. And we have now tried the projection-based procurement based on the moderate case scenario. We are procuring the logistics, and by this time we have the sufficient logistic for more 2 months, and we have the more 6 months sufficient logistics pipeline on the procurement. And these are some strengths. I would like to mention our strength as a laboratory expansion in short time, and the plan protocols and guidelines developed within very short time. We have the designated hospitals, and the most important thing is we have motivated and dedicated health workers working in health facility in the hospitals, and they are doing very fantastic job. I would like to salute them for their significant contribution for the management of the cases. And the key challenge is the management of the isolation and quarantine centers, mobilization of the case investigation and contact tracing team, and emergency management, medical deployment team from the local level. And because we have developed the guidelines and we have developed the policies at the central level, at the federal level, but the local level people, they have very limited capacity to mobilize this team, and this is one of the challenge for us. And I would like to mention the future directions about the COVID response. We are trying to expand the laboratories in more remote provincial locations, and we are also trying to establish more isolation centers and the quarantine centers at the border side of near to the India, and we are still trying to establish. We are trying to enhance the capacity of the case investigation and contact tracing team, and we are trying to resume our routine health services despite the management of the COVID cases. These are some of the lessons learned from us. The lockdown announced by the government was very timely, and it was very effective for the flattening of the epidemic curve. And the high-level political engagement, the initiation and leadership by the Deputy Prime Minister, it ensures the engagement of the other sectors, and the multi-sector engagement and the multi-sector coordination was very effective. And we are experiencing during this pandemic situation, only the domestic preparedness is not sufficient to manage the problem. And we feel that neighbors' cooperation and regarding the international health regulation, implementation of the provisions of the international health regulation is very crucial. And the most significant thing is the role of local level authorities for the quarantine management and the contact tracing was very nice. And despite there are some limitations and some space to be improved, but the quarantine activities and the contact tracing activities, they have done very well. And these are some considerations during the COVID-19 pandemic situation. How can we resume the continuation of the routine health services like immunization services, family planning services, basic health services, and other emergency healthcare services? And the important thing is during the lockdown, all our economic activities has been disrupted. And how can we resume, or how can we maintain the minimal economic activities for the survival of the people and for the survival of the economic system? And the next thing, important consideration is how can we ensure the effective coordination and the collaboration among the three tiers of government, local level, province level, and federal level government, and the risk communication to the community people about the factual information and the factual the message to the community people about the COVID-19 transmission and the prevention. And one of the most important thing is what is the role of host countries for the foreign citizens during the pandemic rescue? Because all the international flights has been disrupted, and the country is not able to rescue their citizens who are living abroad, and how the host countries are responding to our citizens, and how the host countries are responding to foreign citizens during the pandemic rescue. And I would like to put these 4 questions for the question answer discussion session. Is there any trade-off between public health and social measures and the economic activities during any of the pandemic situations? Not only during the COVID pandemic, we may face other more pandemic conditions in the future. So that we public health scientists need to find out any trade-off between the public health and social measures and the economic activities, and how can we adapt our routine life and the social functions with the COVID situation. We cannot expect our usual and pre-COVID life activities and the social functions after this COVID. I don't think the COVID will be disappear in the future. The COVID will remain with us, and we need to adapt our life activities. And how can we maintain the civic code as a responsible civic society people, and how can we convince our people to play their responsibility and the roles as a responsible citizen. And is it the time to think about the health system reform? Do our health system effectively respond to this COVID pandemic problem, or we need to think about the reform of our structure and our design of the health system, or only there is a problem of functional arrangement or the coordination? I would like to put these points for the discussion. And nowadays we have lifted our lockdown situation, and we are trying to resume our economic activities. And is there sufficient precautions followed considering the COVID transmission, or is there still the risk of COVID transmission, and how can we balance the COVID transmission risk and economic activities? And thank you. I would like to promote the Nepalese way of greeting, namaste, to stop the virus spread. Thank you all, and I would like to answer any of the queries in the discussion session. Thank you all. Thank you.
Thank you so much, Bim Prasad sir, for all your presentation and the major highlights about the Nepal on COVID-19 situation, responses, and lesson learned. So we have already exceeded the time limit for the presentation, so we would like to quickly move on to the Q&A sessions. Thank you all the presenters for all the wonderful presentations and sharing your insights or everything on the COVID-19. So we have several questions that have been submitted in the chat box. So we will be able to get through as many questions as the time allows, but I guess we have a limited time for that also. So first question is directed to Carlos. The question is there any impact on COVID responses activities due to frequent change in the health ministers? And another question is there any good practices that was adopted in the indigenous population that you can share examples? I request Carlos to make the answer very short. Thank you.
Hello, thank you, Sabina. In relation about how is Bolivia doing, who is the first question that is mentioned in the chat box also, I want to show one figure, please. Right now, this is the current situation of Bolivia in the sense of number of cases. We are around with 75,000 confirmed persons with COVID. And also something that is really suspicious is the number of suspicious cases, that is around 50,000. That means that maybe we have a sub-register of the real number of persons with this disease. Also that we can check that between regions there is a lot of differences in the number of cases confirmed. For example, Santa Cruz, it have around 50% of the total cases of the country. And we still have almost 50,000 active cases of the 75,000 cases confirmed. Will you please repeat me the second question? I couldn't hear the...
Yeah, second question is that any good practices that was adopted in indigenous population that you can share?
I think that the best strategy that they are taking now is the self-organization. They are owners of the regions. So in many cases, they are deciding to close their borders. They decide how to isolate different persons who are suspicious of having COVID. And in some cases, the government also sent some mobile groups of medics who are also taking samples of suspicious cases. That is the most information that we have. But in any case, there is not so many information about what's happening with them. We know that they are really vulnerable population, but the isolation creates also a scenario where we didn't have what is really happening there.
So thank you so much, Carlos, for the response. So next question is directed to Dr. Guinter. The question is, you initially talked about federalism in Germany. What is your view towards federalism and response to COVID-19? And got an additional question that female leaders are more likely to manage the pandemic effectively. What is your view towards leadership in Germany? So over to you, Guinter.
All right, can you hear me?
Yes.
Okay, so the whole question is about leadership. And if I got you right, then with a certain focus on female leadership, is that correct?
First about the federalism and its response to COVID-19, followed by female leadership.
I mean, you know, this is a phenomenon that we have seen in Europe all over the place, also in the past. So you need to find a balance between, you know, joint responsibility and then only caring about your own advantage. Yeah. Of course, the governance of a very rich, very easy to control small area will always try to be independent from the rest and just keep all the funds and resources for themselves. That's very natural, right? Your treasure box is full, you don't want to share. Now, I think for this you need to have and to provide strong central governance structures. I mean, I'm from Bavaria, and we have a very strong minister and strong governance structures here in Bavaria. And of course, Bavaria was hardest struck, especially in the beginning. And then probably we had some advantage because we were able to move independently. And we saw that governments and politicians from more northern and especially eastern states of Germany, they were actually not accepting that there is really a problem because they were just lagging behind. So we need to find a balance. I'm not completely against federalism, but we need to have strong central structures, and there can be some advantages, but they need to be balanced. Now about female leadership, well, of course, we still have in the top positions in any kind of structure in Germany still a shortage of female leaders. Well, but anyways, I mean, our chancellor, the strongest person in the whole system, is female. I don't like her party, but I like very often her ways of being really reflective and not reacting immediately in a very unreflected way. And I think this is quite a recent characteristics, probably more at home in female persons than in male persons. So actually our topmost leadership is female. And we have quite a number, a very prominent virology researcher here in Munich is female. And so we do have very strong female positions in the whole network. I don't see so much of a gender disbalance with regard to that in Germany, I have to say.
Okay, Guinter, you have got another interesting question. I guess most of the audience would like to hear the answer regarding this. The question is, how research has been done in vaccine formulation in Germany?
In vaccine formulation?
Yeah, how the research has been done in vaccine formulation.
Yeah. I mean, Germany has a long history in vaccine development, and I mean, the vaccine study that we are involved in is a messenger RNA vaccine. So the idea is that you apply messenger RNA. So this is genetic information, but this is contrary to a lot of rumor not being implanted in the genetic information of humans, but it's actually the blueprint of enzymes that are then producing proteins that then in turn again are creating an immune reaction. So this is a way to very easily design vaccines and to produce them in high numbers, which is important, especially in pandemic situations where you need to react in a very quick and in a very efficient way in a large part of the population. So actually there was a lot of research already being done on this. And so now we are more talking about safety profile of the vaccines. So, I mean, we are very prominent, I think, in vaccine research. What we did see, of course, is lots of problems in terms of outsourcing. Many elements of the industry, also of the medical and life science industry, has also been outsourced to other countries because it was economically not so efficient. So lots of things were happening in other countries, in other regions of the world. So we saw now when there was general lockdown that we had problems with materials, and then we had to also think about how to regain control of certain productions. But I mean, the vaccine is on its way, it's functioning, it's producing antibodies, and now we're just talking about trying to find out safety profiles. This is what we are actually busy with.
Thank you so much, Gointa, for your response. Now I'd like to put questions to Gloria Ivy. So the question is quite long, but I will try to make it short. Gloria, can you hear me? The question is, Ghana has the highest testing capacity in Africa. As many people in Ghana live in slum or in the overcrowded areas, what is the disparity in testing among the advantaged people and disadvantaged people? What is the stratified distribution of cases among various socioeconomic groups? Has Ghana government tried to intervene any sort of disparity in testing? Gloria? Hello? Hello? Gloria, can you hear me? Hello?
Yeah, hello. Okay. So I couldn't unmute myself because you had muted
Okay.
me.
Okay.
That was the
Sorry
problem.
for that. Okay.
Okay, so yeah, long question. Actually, let me clarify that we have not done more tests than any other country in Africa. I think I mentioned some other countries that have tested more than us, but we are one of the countries that has done lots of tests. So unfortunately, I don't have the statistics for testing amongst those in the rural or impoverished areas compared to the rest of the country. But the testing protocol is such that if you have symptoms, you either call a toll-free line and somebody comes over to take your sample. And if you are at a place where you can isolate or quarantine yourself, you can do that until your results are released. If not, you would also be taken to an isolation center whilst waiting for the result. Or in some cases, people report to hospitals and the doctors feel the symptoms are similar to symptoms of COVID. Their sample is also taken. So basically, for now, that is how the testing is being done. For the center in Kumasi that has the mobile lab, I know they have rolled it out in certain hotspot areas to test people with symptoms. But basically, you either have to have symptoms or you are a contact of somebody who has tested positive for now, because as I said, our testing capacity is stretched. So that is how far we can go. That was the first question. Was there another question?
That's the only questions we have got for you.
Okay.
Okay, the next question is for
¿Qué manera influye la planta?
The question is, I guess it's most common questions that we'd like to answer. We'd like to hear the answer from you. The question is how we are testing COVID-19 cases, and as Nepal plan to reopen schools, what preparation is being done by government of Nepal for school reopening?
Yes, Abhinaji, thank you. Thank you for the question. Currently, we have 28 PCR laboratories.
Es factible y aquí se va.
Yeah, Sabinaji, is it fine? Hello?
Yeah, it's okay. You can go ahead.
Yeah, currently we have 28 laboratories for the RT-PCR testing in 7 provinces, and all health facilities, including district level hospitals, provincial hospitals, and the federal level hospitals. The clinicians, if they suspect the case, COVID cases, and then they say collect the throat swab and send to the laboratory. And the next way of collecting sample is if we have the history of any people has a history, travel history in the more concentrated cases location, or they have the exposure history with their family and the friends, and if they have the contact history, even some health workers, in the hospital workers, in the security personnel, if they have the exposure history, then the health workers collect the throat swab and send it to the PCR test laboratory, and we do the testing like that. And the next question is about how government is preparing for the opening of the school. Nowadays all the schools has been closed, and most of the schools, public schools basically, they are used for the quarantine. And once there was almost 200,000 people, return people from different parts of the world, from different countries. They were kept in the quarantine in schools. But nowadays we have only 4,000 people are living in the quarantine, and now we are requesting the local level authorities to empty the schools, and then we will disinfect the schools by spraying the chlorine solutions, and then we will we will prepare for the students and the parents about disseminating different public health messages and the COVID-19 transmission minimization precautions. And we are drafting the resuming the education activities during COVID pandemic guideline. And within 1 or 2 days, we will finalize that guideline with a discussion with the officials from the Ministry of Education, and then we will announce that document to public use. And then I hope by 15th of the August we will resume the education activities in the schools. I think I could answer the question by Sarnaji.
Yeah, thank you so much, sir, for the questions. Now, we may take 1 or 2 questions from the attendees themselves. So you may raise your hand. Only a few questions, 1 or 2 questions. So, Claudia, so can you please share your questions among the panelists who you want to ask the questions?
Yes, hello, I'm Claudia from Guatemala. And the question is for Dr. Gunther. Thank you, Doctor, for your excellent presentation. And the question is about the currently availability of tests at community level, especially at enterprise level and home level. And what kind of tests, if they are approved, what kind of tests are they using?
So, Gunther, you can unmute yourself. I have enabled that functions. Gunther?
All right, now it works. Can you hear me?
Yes, we can hear you.
Okay, so the question was about availability of testing. Right now, the availability of testing is, I mean, if you talk about the materials, so swabs, media, and laboratory capacity, I think we can pretty much cater for what is needed now in terms of what the primary healthcare workers can provide. In Germany, we have a system where we have family physicians. So this is the frontline contact to the public. So usually, if you feel sick, you go to your family physician. Yeah, so this is almost like a privately run business, like an apartment or a house, and you have your private practice there. And then you go there and you say, well, I feel sick. So a number of physicians in the front line have decided, yes, I will do the testing. So they have allocated rooms, they have taught themselves how to put on and off properly personal protective equipment, and then get in contact with the laboratory to do the testing. There's quite a number of family physicians that did not do that, that say, I'm not going to do that. I don't want to have any of these patients in my premises. So it very much depends on where you live, actually. There are some places, or a lot of places, I would say most places in Germany, where now it's not so much a problem of capacity, but more a problem of finding someone that is willing to actually test you. And then there are official places where you can get tested. Our tent out here in front of our institute, we have tested about 4,500 people so far, but we have limited ourselves to a very special clientele, which is healthcare workers and old people home employees. Yeah, so we are testing other healthcare workers that are at a higher level of risk and that we would like to make sure that they can continue their work. So it depends pretty much. But yeah, it's not a question of lack of material currently.
Okay, thank you, Dr. Guenter. So I'd like to thank all the presenters and all the presenters for sharing their presentations. We are grateful for the time and effort you took to share your country-specific situation responses and lesson learned on COVID-19. And I would like to thank all the attendees, participants for your time and patience and asking questions to the panelists. So thank you again for helping make our webinar so rewarding. With this also, I would like to inform you that we have more of this webinar coming shortly. So the next webinar we have planned for August. We shall share you the information in our website, in our Center for International Health website too. We hope you will be able to join us in the next webinar also. I guess Deepak sir has something to share apart from that. So any closing remarks from Deepak sir? So over to you, Deepak sir.
Thank you, Sabina. Can you hear me?
Yes, we can hear you.
Yeah. Thank you for moderating this session. I would also like to thank all four presenters for presenting this one. Sabina already explained that we have plans for upcoming events, and this is just illustrative list, and this is subject to changes based on availability of speakers, based on the emerging situation. We might change the plan, but generally speaking, for next month, we'll kind of repeat the same program, but for new countries. And countries under considerations are Afghanistan, Bhutan, Tanzania, Italy, and Guatemala. Again, you'll be able to hear experience or situation from Asia, Africa, Europe, and South America in our next session as well. And then we have some sessions planned around health systems, equity, or how do we protect the poorest, diagnosis and treatment protocols and systems and what we learn. And today also we heard interest on vaccines development, so immunology and vaccines and COVID-19. So these are illustrative list. This might change a little bit based on availability of speakers and interest from other participants. And we'll like to hear from you how you felt about this kind of programs. Some of you were asking for information on the PowerPoint slide for this program. So those PowerPoint slides will be uploaded in CIH website, so Center for International Health. So we are in communication with Center for International Health, and once they are posted there, all registered participants will also get notification by email. Otherwise, you can check the CIH website in a few days' time to access the PowerPoint presentation as well as recording of this presentation. And we'll also be announcing about our upcoming webinars, discussions, and management. And we'll also be sharing about those upcoming events and other products that we are developing through One Health Knowledge Café. So on behalf of One Health Knowledge Café collaborators, I would like to thank all of you and would like to close this session for today. Thank you.
Thank you all. Bye-bye.
Thank you. Have a good day, good afternoon, good evening, everyone.
Yes, thank you. Thank you, everyone.
Thank you. Bye-bye.